think for the attendees at this meeting, and maybe past president of the American Head and Neck Society, Terry, is proving that New York is a city that never sleeps. So unless you sleep during the sessions, so we'll watch for that. It's a pleasure to be here. These are very wonderful people to work with and distinguished people to be on the same panel with, and I thank you for that, and thank the organizers for the invitation. So my question, and interestingly, sometimes these things just kind of work out, that none of this was essentially pre-rehearsed except for Ross and I changing everything we were going to do last night about midnight, I think. But the others weren't. And so it's interesting how I think this is probably going to fit. And my topic was, as it says, oral cancer screening. Is it effective and is it necessary? And I think you've heard some comments on that already. Just go ahead here. And I have no relevant disclosures to this topic. So the outline of what I was thinking of doing was presenting what's been learned from other screening diseases, including other areas of oncology. And based upon a recent screening program at ASCO, I have chosen breast cancer as the model, which is interesting that we both chose that. And I'd like to thank Ross for presenting the diagnostic adjuncts. Initially, he was talking primarily in the context of cancer identification, which is different than looking at potentially malignant disorders or mucosal lesions with risk. And that was essentially my talk, but he rolled that into his. And then I thought I would end with a discussion of the issues and where we stand with related to early detection and screening potentially, and the implications for clinical practice, what we actually probably should be doing as organizations working together to develop guidelines and improve the field. So basically in breast cancer then, they've been really looking at was described at this meeting in Chicago in June, just a month ago, it's a new paradigm, that there are lesions that are indolent that will probably never progress, or that may regress. And that's different than the linear model that we used to see of accumulative changes in the genetics of the cell leading to ultimate malignant disease. So in the first column, early detection will not improve mortality. Slow progression is what we usually anticipate, and that's where this delay in diagnosis is often identified as allowing the disease to be upstaged or present at a more progressive state, and ultimately early detection would reduce mortality. And then there are diseases that they're classifying as rapidly progressing, where systemic therapy is truly the key. And early detection would be helpful, especially if you could identify it prior to this rapid progression. So in this graph, you'll see in the first column, which is the rapidly progressing tumors that present from the genetic change or molecular change to microscopic disease to then localized clinical and spread disease. With rapid progression, screening will likely have minimal benefit. On the other hand, screening for undetected disease may be effective for those that are slowly progressive, that model that we're used to thinking of accumulative disease. And that would be the maximal benefit. And of course, potential harm, which is really the emphasis of many of the screening approaches in various malignant diseases, is detection of disease and treatment for something that may either regress or is indolent and non-progressive. So this is part of the data that they presented was based upon a Canadian trial that looked at about 100,000 women, half of whom were evaluated with mammography and half of whom were not. And you can see the outcome at the end was those that were assessed with mammography, that 500 died from breast cancer, whereas 505 would have died in that study based upon the follow-up and based upon not being evaluated with mammography. And you know the controversy about mammography, how frequent, what age you begin at, is it yearly, now is it biannually, and is it 40 or 50? Does it depend on a history of risk that may be familial, and a number of other nuances that are clearly being discussed. But one of the things that this has done, and I think this is an interesting summary, is that 30% of the screen-detected cancers were ultra-low risk disease. In that setting, does therapy carry more risk as an outcome than observation? And we can start to think of how we are applying this in our thinking to oral and oropharyngeal. Okay, so in breast cancer screening, this is the summary. Early detection saves lives. Well, maybe that's too simple. Maybe that message needs to be modified. And in fact, that was the message of this session that involved a number of presenters, is that we have to tone down the rhetoric because it has to be related to the outcomes that matter. Progression then. Are we overdiagnosing and overtreating the lesions that won't progress or may reverse? And certainly not knowing the natural history of many of our mucosal oral lesions, let alone the HPV lesions, are we overtreating and overdiagnosing when we identify the potentially malignant disorders? So the detection of risk lesions and progression of cancer. We need to be able to then at some point in all cancers, and other examples exist that are very obvious, like prostate, cervical cancer. Can we differentiate the idle or the indolent lesions or the reversible ones? And can we push the reversal down the road so that we actually prevent cancer? And that's where screening then becomes valuable. We'll talk a little more about that later. So as management, though, of the disease, of the cancer, becomes more effective and more therapeutically advantageous, screening may be less important because we can actually treat the disease once it clinically presents at a potentially later stage. So the other issues were, and I think this is an important part of our discussion, is we have pushed people to think screening matters. And you remember when the guidelines have changed in probably all the countries that you represent, there's protests that I want my mammogram or I want my pap smear or whatever it may be, and they want it now. It's like the commercial. Anyway, women's perceptions then of the effect of mammography in the top part of this slide, out of about 1,000 women, 80 thought they would die from breast cancer, just as a public survey, and actually 44 would die from different causes with screening. Without screening, they thought it was double. So the public's estimate is screening reduces cancer death rates by 50%. But when you look at the real effect based upon this paper in New England Journal that was recently published, again, about 1,000 women, the actual numbers are 4 die from breast cancer, 44 or 45 die from other causes with screening, and 5 die from breast cancer with screening. So the public is very enthusiastic about screening, and while this is a slightly older trial, 10 years ago, it was a phone survey of 500 adults of patients that didn't have cancer in their history, and they asked about the screening technologies that have been applied to them. So it was mammography, pap smear, PSA, and colonoscopy. 38% reported at least one false positive screening test. 40% said this was very scary. Even with that, 98% felt that the test was appropriate and they were glad they had it done. 87% said it was almost always a good idea, and 66%, I think this is interesting, wanted screening even if there was nothing you could do about the disease progression, which actually may be the case in some of the oral things we see. So I'm going to switch to the oral a little bit, and thankfully this has also been presented. So this is the Kerala, India study you saw. I have slightly different presentation of data, obviously, but 41% who were examined with a flashlight and a tongue depressor by trained field workers were identified at stage 1 or 2, whereas in the control group, 23% were stage 1 and 2, and these were those who were not specifically having an oral intervention. Now, of course, India is a high-risk disease community. You have to know about the population. And so this one study is one of our leading measures of is screening or examination of patients productive in that setting. Another study that I thought I would highlight at this point is an 8,000 patient sample. It was in Taiwan. And again, noting differences around the world and in disease etiology, this clearly involves betel nut and probably tobacco in large degree at that time, and may have little relevance to HPV. But this was a double-blind trial where they applied toluidine blue or a blue placebo rinse, going back to what Ross was showing you with toluidine blue. They had trained dentist examiners, and they biopsied these lesions after 10 to 14 days after the first exam if they identified a lesion. Obviously, they didn't biopsy and didn't report what they didn't biopsy. 82% of the T-blue and 91% of the placebo patients complied with the second visit. And if there was a lesion on either, they were biopsied, but they didn't have any data on the non-biopsied lesions, obviously. 5% greater number of potentially malignant disorders were identified in the toluidine blue group. And many of those were associated with submucous fibrosis as the betel nut risk. Then they did a 5-year follow-up of the tumor registry where they identified 11 cases in total of the 8,000 screened that went on to squamous cell carcinoma, and they found no difference. Obviously, this likens back to the previous study in Kerala where it was almost 100,000 people per group to identify cancer as a rare disease in a high-risk population. So we have some real challenges, potentially more so than in some of the other cancers. And this, Ross referred to the new meta-analysis that's being looked at by Cochrane, but this was previously done, and it was a look at the technologies available that Ross listed, including a conventional exam, vital staining, light-based detection systems. And their results in testing a population in whom you would calculate a 1 to 5% cancer risk, that these tests, all of them were better at demonstrating or classifying the lack of disease than identifying a true positive. So the conclusion of this Cochrane analysis was that practitioners should be vigilant for evaluating and identifying when they're there, and through routine oral exam. So what does all this sort of mean, and where do we stand? And then there'll be time for discussion that I think this might lead to. Patient self-examination. Is there any evidence this is effective? And if you look at the bottom of the slide, there's really no evidence. But awareness of signs and symptoms, which Terry alluded to, may be something that we need to provide more education, more opportunity for this to occur. So that gets back to patient symptoms and patient self-evaluation, and then obviously potentially presenting for diagnosis. History, risk factors, symptoms, clinical examination. These are all the things we have available, and Ross listed them. A few things that I think might advance the diagnosis and ultimately the intervention is molecular testing of cells that we collect in different fashion, whether it be by mouth rinse collection, whether it be by cytologic cell collection, or on tissue biopsy. And I'll mention a little more about the HPV issues in just a second. Now, in actually North America, particularly in the United States, the U.S. Preventive Task Force completed a report that was published almost a year ago now, in 2013, that led to quite a response from people in the oral care and the head and neck cancer group. And in the end, the task force recommended that the current evidence was insufficient based on balance of benefits versus harm for screening for oral cancer in asymptomatic adults, but they specifically, after input, excluded experts at tissue evaluation and head and neck experience, and that would be dental providers and otolaryngologists. So we have some evidence or some statement that's, as Terry was mentioning as well, that screening of asymptomatic individuals may not be specifically indicated and may be fraught with additional risk, including the false positives. So a couple other things I thought worth mentioning is the screening has an impact on malpractice liability, and I think that was alluded to earlier. So failure to diagnose and delay in diagnosis or delay in referral are very common in malpractice cases throughout North America and Western Europe. Part of the problems that exist is the screening guidelines are variable and they're not very well defined. There's a historical and public belief that screening is positive and good, as I showed, and effective. And the other perception is that advanced stage disease means that it was missed at an early stage. And that has a lot to do with tumor doubling time and progression, and doesn't necessarily correlate with time, as we know. And there's precedent cases in the law. So there is malpractice liability associated with the work that we do. In fact, in all ways, but in this way in particular. So the needs, I think, that have been discussed and that we've presented as well, is that local standards should be looked at in addition to guidelines, that state laws in the United States and safe harbor laws, if you follow rational guidelines, should be supportive. It comes down to education, it comes down to evidence-based, and it comes down to research, the same things that Terry said. So again, what are our considerations? Are we screening for cancer, or are we screening for mucosal disease? If it's mucosal disease, the risk of identifying potentially malignant disorders carries with it the risk that we all share in management, and that was just presented, that we're not really very good at preventing that potential progression, and that I think will be interesting in discussion if people bring that up. Clearly, early stage disease has lower cost of treatment, lower morbidity, and lower mortality, and that's of cancer, not of the potentially malignant disorder. Can we prevent new primary cancers? And obviously the interventions, the trials, the technologies that we need to use are hopefully becoming available. And what's the cost of screening versus the cost of care? We have, if you look at the pap smear costs or the mammography costs nationally and add that up, it's going to be hard to win an economic argument. We're behind that line because we're behind the curve in trying to institute some screening technologies, which we still have really yet to develop. But will it ever be cost effective in a low incident disease, even if it's a high cost disease once it occurs? So what about overdiagnosis and overtreatment? It's easier to advocate for more treatment, and this is from that breast cancer discussion. Increasing awareness may increase potential harm. Increased testing, increased cost of care and diagnosis, and anxiety and cost of care, as I just mentioned. So are we doing in breast cancer, the question is, too much treatment for low-risk disease? So for us, potentially malignant oral lesions or oral potentially malignant disorders, PMDs, and needs to be separated from oral pharyngeal for many reasons, and this meeting has covered many of those. Do we know if there is a pre-malignant detectable condition or even an early cancer detectable lesion in the oropharynx that's HPV-associated disease? You heard that most of these are identified, and you're probably aware, with a mass in the neck or some other symptom, and often it's hard to find, or the primary still can't be found. So we don't know if there's a precursor condition that we can identify or a technology that we can utilize specifically for oropharyngeal patients. So should we be looking at different patient groups in different ways? And I think Terry really emphasized the importance of that, which obviously this supports. We need better prediction of biology. How many and which ones of these are progressive, how many may reverse, and how many may remain stable? And in that way, we're like really every other oncologic disease that's being investigated and treated. What's more effective and what specific treatments might prevent that needs to be defined. The patient should be engaged in awareness of what our knowledge base is, what our therapeutic options are once we identify a condition, and so we have to be data-driven. What can we do now? Again, involve patients in the discussion of what we know, what we found, what the therapy could be, and what the best recommendations currently are. Should we follow longer before biopsy once we identify these lesions? Are there surrogate markers we could use? And less surgery for biopsy in breast cancer. So we really have, I think, more questions than answers, although I think the panel is going to summarize our view of screening of asymptomatic individuals as not actually indicated. We don't know if there's more harm than good, as I mentioned. Is a detectable early state of disease, again, oral, maybe. Oropharyngeal, maybe not, or maybe less so, or maybe harder to identify. Can we, through mouth rinse or throat culture rinses, collect cells or markers that may predict? And that work has been done over the years, not so much since the oropharyngeal cancer HPV increase has occurred that I'm aware of, at least, so we should discuss that. Is there a benefit or risk from detection and intervention for the potentially malignant disorders versus early detection of squamous cell carcinoma? What is the progression? How can we predict regression versus impact of treatment? And again, this is a low prevalence condition, so how do we increase our yield? It was easier to say, well, it's people over 50, or maybe older than that smoke and drank, but now that's changed. And so we have to redefine our groups in a different era and then identify who may benefit if we can prove that. And opportunistic screening is a term that's been used when you're at your dental office. They should be looking and completing a complete exam. And just a couple other points on this slide right in the middle. The adjuncts or tools that might assist us and our clinical investigation, as well as histopathologically, needs to distinguish between inflammatory and benign conditions, inflammatory being common, and potentially malignant disorders of the oral cavity, and squamous cell carcinoma. And it's a challenge for all of these adjunctive devices to separate the inflammatory from the potentially neoplastic. And again, the HPV. So increasing awareness. And I just wanted to end with this last slide. That was the end of that session at ASCO, which said, tone down the rhetoric. Given the disease burden caused by, insert your disease here, which reminds me of an old movie, Animal House, none of us should raise our screening and treatment thresholds at this time. So I'd like to thank you for being here and showing that New York never does sleep, and I know we're happy to take questions. Thank you.